The next speaker, Dr. Jodhbir MEHTA. I think he needs no introduction here, and the speed at which he speaks is sometimes very difficult for our Indian brains to catch up with. Yeah, and Jod has been a wonderful teacher when I did my international fellowship at SNEC along with Tan and Jod here. And his work in being a clinician scientist and his insights into almost all aspects of cataract refractive cornea ocular surface is something which we all look forward to listening to always. So over to you, George, and we invite you to speak on the importance of effective lens position.
Great, thank you, Vanathi, for the introduction, and it's very nice to be back in India again for my first visit this year. As Vanathi said, most of the time I specialize in cornea and cataract refractive surgery. Can I have a slide? Great, thank you. I think that really cataract surgery has changed immensely over the last probably decade and a half, and now most of us would probably consider cataract surgery almost becoming into a refractive procedure for many of our practices. And I think that as a transplant and refractive surgeon, we have to approach our cataract surgery slightly differently with really the high standards that we all try to obtain basically when we consider refractive surgery as well. These are my financial disclosures. So last year was a significant year really for any of us doing cataract surgery, where we celebrated the first implantation of the IOL performed at my medical school by Harold Ridley at St. Thomas's. This is the plaque outside St. Thomas's Hospital, and when I was a medical student there doing clinical work, our house where we stayed was actually named after Harold Ridley, and there's a lot of history behind how we came up with the first IOL implant. But it's very interesting that despite the first inaccuracy of the first IOL that was implanted with a residual error of -20, because there was a slight miscalculation done on the refractive index of the PMA optic, over the next 12 years, really put in 1,000 implants, and it's amazing how accurate the biometry error was, considering these are the first IOLs implanted inside the eyes. And you can see over the years we've got better and better with our accuracy itself. And we can obviously get better data when we're looking at single surgeon studies compared to basically looking at large cumulative databases, but there's been improvement within our accuracy. This paper that we wrote in the Lancet back in 2017 showed that basically how cataract surgery has evolved, and really the way we think about modern cataract surgery for many of us, where it's changed from a therapeutic procedure into much more of a therapeutic or refractive procedure as well. And that's where we start thinking about things with outcomes, whether it's astigmatism control or even presbyopia control, and really looking at lifestyle of our modern patients as well. And with people living older around the world, of course, their range of their lifestyle or quality of life becomes much, much more of an important issue. And of course, now we're doing a lot more work with computerized stuff that, of course, has become much more important for our visual needs. And one of the drivers for this is really the table on the right-hand side, where you see a reduction in the complication rates from cataract surgery. So the two things have to basically go hand in hand. When we look at errors basically in the outcomes of basically modern cataract surgery, you will see that the largest errors, of course, have been related to axial length, IOL power calculations related to obviously the A constants of the lenses, and basically capsulorhexis sizes as well. And a lot of these are basically been improved upon over the years with respect to automation, improvements in biometry machines as well, and this has really significantly reduced our errors. However, one of the areas with respect to IOL accuracy is trying to understand the position of the lens following the surgery itself, and we call this basically postoperative effective lens position itself. And you can see that this can affect the way you're basically going to think about adjusting your A constants or where the lens is actually sitting in, because this is a variable when we put it inside the bag that we cannot control with most of the lenses that we use. If you look at most basically newer generation IOL formula calculations, they're very accurate when you look at the axial ranges within the middle zones over here itself, but at the extreme areas we get basically less evidence of accuracy, and you can see that in the MAE, or the mean absolute error, when we're looking at our outcomes basically following surgery, and a lot of this has got to do with the positioning of the lens itself. When you think about ELP, many of us will be familiar with the fact that obviously we're aware that when you look at basically the change in IOL position, it's going to affect basically the refraction itself, depending on it's more anterior, more myopic shift, or basically more posterior, slightly more hyperopic shift itself. And we can apply lens formula calculations, basically either using a thin lens or a thick lens eye model to try to basically understand this itself. You can calculate using mathematical formulae to understand the shift in the haptic position with respect to what will be the refractive change. And this is formula from Damien Gatinel's paper, which will basically show you the effect of when you basically, the IOL will basically shift itself. And when you plot this, basically measures of outcome, basically when you look at dioptric change versus the dioptric IOL, or the power, of course, the higher the power of the IOL, when you have a certain significant amount of shift, then you're going to have a basically much more of an effect as well. And likewise, when you can basically calculate this with respect to dioptric powers of your keratometry as well. So these two things obviously will basically go hand in hand. Now, all of this that I've shown you so far really applies to when we're thinking about monofocal IOLs, and we understand the effect that it can basically have. But of course, you know, Douglas Koch gave an excellent lecture talking about the modern day cataract surgery, where we're looking at diffractive IOLs itself. And when you're considering diffractive technology, when you're putting that inside the eye, you must consider not just basically movement that's axial, so basically anterior and posterior, affecting your spherical equivalent result, but you must consider non-axial deviation, because if you put a diffractive lens inside the eye and there's basically non-axial displacement from capsular fibrosis, then it's going to have a significant effect on your outcome. And likewise, if you have cataract surgery in your 50s and 60s and you're living until the mean average age now in Singapore is about 88, Japan now 92, and you're living for another 25 years, if you do get a shift in the diffractive rings, it's going to basically affect your outcome. You can just see this in a patient that was sent to me. This is the visual acuity result on the right and basically on the left eye. And the patient told me they had bilateral diffractive or multifocal lenses, and if you look very closely in the picture on this side, you can just see the diffractive rings on this side, and this side actually I couldn't see any diffractive rings, and I said, are you sure you had a bilateral lens? When we dilated basically the patient, and you look at this in a bit more detail, you can see the diffractive rings over here. You can see the slightly irregular capsular rexus around this side and the rings in the segment. And what's happened on this side over here, you can see the capsular rexus around the edge over here, but you can see this is a non-axial displacement of this diffractive implant, and it's actually basically shifted upwards as the bag has basically fibrosed itself, and of course that's what's caused the degradation in the visual acuity and the induced hyperopic and the astigmatic effect. And of course you can imagine this guy wasn't basically very happy with the results. So of course the first thing I asked him was that basically initially after he had the surgery done, was he happy with the visual acuity result? Because of course I knew this was related to the fact that the rexus is basically not perfectly round, and it's probably one of the issues with the irregular phimosis that's caused the displacement itself. He said it wasn't perfect, it wasn't as good as the other result, but it was basically an acceptable outcome. So I offered him, the lens has been in the eye for almost 2 years at that time, and I said, look, these are our options. We can do a lens exchange, or we can try to basically alter the effect of the refractive outcome and try to improve the visual acuity. So he underwent a YAG, and this was the result from his YAG capsulotomy over here. Now you can see the diffractive rings and how they've been displaced over here. And I said, look, it's not going to help you with your vision result, but let's just see what's going to happen with respect to your reading, but it will improve your distance vision. So his distance vision was improved, and this is a refractive outcome for which he was basically happy. And subsequently, I've done a topography-guided surface ablation for him to reduce his residual refractive error to try to improve his symptoms. Now, one of the issues when we assess patients, obviously when they're having cataract surgery, and why effective lens position becomes a little bit apparent, is there's one parameter that we don't basically measure, and I'll show you this in the next couple of slides. This is the lady who underwent routine cataract surgery by one of our residents. After her surgery, you can see the visual acuity result was pretty good. He was quite happy with the results, but she said that basically she gets a streak of light at 1 month post-op when she basically looks at any single spotlight itself, no difference with scotopic and mesopic vision. This was the same as when they saw them at 3 months. They thought they had some aberration problems, so they basically sent them to refer my clinic. And the other thing is obviously she was worried about what was going to happen basically with the right eye. This is basically what the eye looked like basically at 4 months. So there was no issue with the aberrations, basically you can see on the corner tomography. But if you look closely on the retroillumination, you can see this basically slit, or this line basically over here itself. And it was difficult to ascertain whether this is in the bag or basically at the back of the lens itself. And of course, these are the options that I basically gave her to have a look at, or options basically for surgery. And what happens is that these creases itself can often give basically a Maddox rod effect itself and then affect the quality of the vision. So in fact, basically what happened was is that when I basically took her to OT to basically have a look at this in a bit more detail, injecting a little bit of viscoelastic, when I adjusted the lens, you can see what happens to that line position from the edge there itself. So I adjust the lens itself, I move it a little bit, and you can see that line basically go. So this is a fold that basically in the posterior capsule, that's basically at the back there, and that's what was giving her effect itself. So I try to massage out the capsule itself to push the lens back, to manipulate it a bit. So why does this happen? Well, it basically happens because, of course, most of us never actually measure the capsular bag size when we're thinking about doing cataract surgery, and especially in Singapore, we have a lot of patients with angle closures. They have large lenses. When you're putting lenses inside the bag itself, it's not unusual you can get these kind of streaks basically occurring. And of course, if you can imagine if this was a diffractive lens, you're going to have a lot more visual phenomena than you're basically going to get with a standard basically monofocal. So I adjusted the lens position. She said it was much better afterwards. Then she said to me, what are you going to do basically for the other eye? So again, it comes down to understanding your lens position and how we can avoid these situations. This paper from Susan DeMarcos in basically Portugal shows you the effect using a UBM study of basically the lens position basically preoperatively and then basically postoperatively, and looking at a whole series of IOLs basically inside the eye with a function of the variation in capsular bag thickness. And what it shows you is that actually when we're doing cataract surgery and putting a lens inside the bag itself, it's very difficult to predict exactly where the lens is going to sit itself. And this is what's going to give you minor adjustments, because we don't measure the capsular bag in routine practice, because obviously we're putting the same lens in every single bag itself. So how can you get around this? Well, the lens of choice that I use basically for a lot of my procedures is basically called the FEMTIS lens itself. The way this will work, on the left-hand side, you'll see a video. So we make a capsular rhexis and the ports done with the laser. And then basically once this is created with a perfectly defined capsular rhexis on the visual axis, we will then basically implant the lens. Just for the interest of time, I'll just show you the lens basically going in. The lens has basically 4 flanges on the surface, and it has a refractive basically component itself to help with the optics to give them distance, intermediate, and layer. So once the lens is basically implanted in the bag, you will see you need to remove the viscoelastic from behind the lens. And simply what you do is you will go around and then you enclave the 4 pieces of the flanges onto the capsule itself. So the position of the lens itself is then sitting directly on the anterior capsule. You can simply do this with a Sinskey hook, and you can put the lens into position. There's a toric version of this lens. So when you fixate this directly onto the anterior capsule, the lens is going to remain exactly in the position that you know, but every single case you know exactly the ALP because you know you fixed it directly onto the capsular bag. Okay, so this was basically her post-operatively. You can see the UBM on the right and basically on the left side, where the difference in the lens fixation. On this side over here, you can see it fixing to the anterior capsule, and this side basically into the bag. This is the outcome that you can see from this side, and you can see the fact she was her experience was completely different with the lens that we fixated onto the capsule itself. And you can see a little bit of the induced astigmatism from the lens sitting in the bag after the capsulotomy. And this was with basically a standard monofocal itself. And the advantage especially is more profound when you're doing basically toric lenses, especially in the higher component multifocality lens, or even with the refractive situation, because you can clip this directly in position as well. So in conclusion, there's been significant evolution in cataract surgery in the last 30 years, and lifestyle changes for all of us, basically with more computer, iPad, and iPhone use, basically, and the increasing aging population has increased the demand for spectacle independence, and really has changed our concepts in when we're doing cataract surgical procedure from therapeutic to much more a refractive procedure itself. So we have to hold our standards at a refractive level itself. Technology in this surrounded with a whole lot of different IOLs. It can be super confusing about what lenses to improve itself, but we have to basically look at improving the side effect profile and improving our efficacy itself. The next generation lenses, I think, are basically are required to really improve the consistent accuracy, and this requires a reproducible rhexis, which I've shown you with the femto, but you can do this with many other devices as well. I like the femto as my lens of choice because it gives you an accurate ELP position itself, because you can fixate this directly basically on the visual axis with respect to angle alpha measurements as well. Thank you for your attention.
Thank you, Dr. Mehta, for